Well, hello everybody, and a very warm welcome to this Royal College of Surgeons of England webinar in Focus Ukraine. We had two excellent speakers this evening for the webinar. I think, like many of you, I felt pretty impotent in the face of another humanitarian surgical disaster, this time on account of a war very, very near our own shores. And because we're doing this webinar on Ukraine, doesn't mean to say we haven't really been concerned about any other wars or areas of warfare or conflict in the world around up until now. I think there's a sense that many of our members have written to us and have expressed concerns and worries and wanted to know what they could personally do about something so close to us. And for this reason, we have been speaking to various agencies and we have been talking to many friends around Europe and around the world around what can we possibly do. So I'm going to ask our two panelists to introduce themselves. First of all, Chris Moran.
Hi and good evening, everybody. My name is Chris Moran. I'm an Professor of Orthopaedic Trauma Surgery working in Nottingham, and for the last 10 years led the development and of the English major trauma system. And then for the past 2 years, I've been National Strategic Incident Director for NHS England, dealing with obviously the COVID crisis, which has been the biggest incident we've ever faced, but also other incidents such as monkeypox, Lassa fever, and latterly for the last 100 days or so, Ukraine.
So as though COVID and all the other things weren't enough, Chris, you've now got another crisis in your hands in another jurisdiction. Well done. Lizzie, please introduce yourself.
Many thanks, Neil, and good evening, everyone. My name is Lizzie Marmont. I'm the Senior Operations Manager for UK Med, who I'll look forward to telling you all about in a few minutes. I'm here today to talk to you about UK Med's work in Ukraine and give you some first-hand insights as I recently returned from a 2-month tenure. Thank you, Neil.
And just to say, Lizzie has experience in the British Armed Forces, in the medical services, and I think Chris is an advisor to a number of the Defence Medical Services core functions. So I think without any further ado, Chris, I wonder if you could give us an idea of the big picture in terms of what are we doing and what can we do to help both the military and particularly the civilian casualties of another armed conflict very near to our shores. Chris.
Great, thank you very much, Neil. I'm going to concentrate on sort of giving a bird's eye view of everything that's going on. And I think generally, it's honest to say that we haven't seen the level of impact on NHS services that we were planning so far. And I have to say that is a really good thing. And most of the NHS response has been able to be absorbed into business as usual within the massive organisation that is the NHS. A lot of work we're doing has been regarding signposting new arrivals into the NHS, into services, so that they can access the services. So I'm going to touch on a few things this evening over the next 10 minutes or so. First of all, what we've done in terms of medical aid, providing equipment and supplies and expert advice, how we've been caring for those who have been fleeing the conflict, including care for a group of sick children who we evacuated, some children with cancer. I'm going to talk briefly about our preparations for casualty evacuation for war wounded people, and then touch on a couple of other things such as preparations for cyber attacks and CBRN, which is something we just need to keep in the background. So in terms of medical aid, we've had a huge number of offers from throughout the NHS, including all of the Royal Colleges, particularly the Royal College of Surgeons. And we very early on established a single point of contact for offers of donations and requests for assistance into the NHS. And this has allowed us to have a coordinated effort rather than lots of things happening sort of at random. And for that, we've had key input from the Ukrainian government, particularly the Ministry of Health, to identify key requirements. And we've also worked with the NGOs and the World Health Organization. In total, so far, the NHS has delivered over 11 million medical items into Ukraine, almost all via Poland. And it's important to say that those have come from NHS stocks. They've not denuded care at the front line within the NHS itself. That's included almost 7 million doses of medicines. And in fact, one of the earliest medicines we sent out was insulin, because there was a shortage of insulin. They had very limited stockpiles within the country. And those we were pleased to see, because they still have a remarkably resilient supply chain within Ukraine, reached frontline areas really, really quickly. We've also sent 250,000 wound care packs, as well as specialist or brain and spinal injury equipment. The big ticket items have been a pledge of over 20 NHS ambulances. Quite a lot have arrived now, with another 22 ambulances to arrive, and 40 fire engines, all of which were requested by the Ukrainian government. In terms of expert medical advice, that's been largely provided and rightly provided by the experts, the colleges and the professional bodies, rather than NHS England. But clearly the people providing that advice are all working within the NHS. In particular, the British Orthopaedic Association and the British Association for Plastic, Reconstructive and Aesthetic Surgery, the plastic surgeons, have been running a series of webinars in collaboration with the Ukrainian Orthopaedic Association on the management of war injuries. And those are joint webinars between Ukrainian specialists and specialists from this country. A small number of experts have gone in on the ground into Ukraine, but those have mainly been provided by NGOs such as UK Med, and we're going to hear in great detail from Lizzie about her experience and what UK Med have been doing. I think the requirements there have been very much a mixture of primary care and then some super specialist care, such as reconstructive surgery for bone and soft tissue loss. So there's been minimal NHS England direct involvement in this, but we have very much encouraged hospital trusts and managers and chief executives to support any NHS staff who volunteer and are willing and able to help. So in terms of care for those who fled the conflict and have come to the UK, this has undoubtedly had the biggest impact so far on the NHS. But as I've said at the beginning, it has been much smaller than we had planned for or expected. At the moment, the UN Refugee Agency estimate that 4.7 million people have fled Ukraine, and that's mostly been women and children. And you know, to put that in perspective, the terrible events in Syria, it took 3 months to where we are now before 1 million people had left Syria. So the humanitarian crisis is really hard to underestimate. But so far, the last data, which is from the very beginning of this month, shows that we've had 143,000 applicants for visas into the UK. 120,000 of those have now been issued, so the majority of people who have applied for a visa have now been issued with a visa, and so far 65,700 visa holders have arrived within the UK, and every one of those is going to need some form of medical care. The main impact for the refugees is going to be in refugee health, so that is going to largely be within general practice, dentistry, we should never forget, children's and maternity services, and also mental health services, which I'm sure is something that Lizzie will touch on as well. We've got to also remember the wider public health impacts, and so arrivals, once they're registered with a GP, then need to get screened, check their vaccination status. That's not just for COVID, it's actually for all the important childhood vaccinations, because we know that vaccination uptake is not particularly high in Ukraine, and also check for diseases such as tuberculosis, obviously particularly on the lookout for multi-resistant TB. So probably the most important action from a healthcare perspective for the refugees arriving to Ukraine is to get them registered with a GP, and that then allows them free access to NHS facilities. And a lot of work has gone in terms of language translation and communications to those arriving to make it as seamless as possible for them to start to join our healthcare system and start to understand how it works. And we've also working very closely with the social care sector, because obviously it is a combination of health and social care that these people require. We've made preparations, and we have to be aware of the possibility of having to deal with issues that we don't normally deal with, such as, sadly, the victims of war rape. And so, although these things aren't headline grabbing, there's a huge amount of work going on in the background in order to prepare the NHS to receive and assist these people. Seems ages ago now, but just a few months ago, we also ran a medical evacuation of 21 children with cancer, because cancer services had tried to keep going within Ukraine, but were struggling to provide good oncology care for children. So we evacuated them along with their close family to support them, and those are now being managed successfully within our specialist children's oncology centres. The next thing I'd just like to briefly touch on is the situation with war casualties, which everybody watching the TV and we see a very sanitized version of war with our restrictions on visual reporting in the UK, but it's easy to imagine the terrible injuries that are being inflicted on both civilian and military casualties, and that's military casualties on both sides. So NHS planning was completed very early. We'd started well before the invasion in anticipation of problems. So we have a concept of operations for the whole of the UK should we need to receive civilian battle casualties from Ukraine, and that includes children and adults. But as I mentioned earlier, thankfully so far the numbers coming out of Ukraine severely injured has been relatively limited. We've taken a four nations approach to this planning, and the care of battle injured people or civilians but injured will be focused into the major trauma centres in the home nations. The has to be said, I think, Lizzie will give us more insight onto this, but from where I'm sitting, the Ukrainian medical system has performed remarkably well so far and proven itself very resilient. The whole of their health service has been put on a war footing and is focusing on the management of the war wounded, both military and civilian. But we probably have to recognise that that will inevitably have a knock-on effect on other services, akin to what we've seen here from the pandemic. And so the war is going to have a far wider and long-lasting health impact than just those who get wounded. The Ukrainian surgeons are generally experienced in managing war injuries, and that's because, of course, they've been involved in the conflict in the Donbass for the past 7 years. We have identified a number of areas where they need some super specialist support. That particularly includes plastic surgery for free tissue transplants, so free muscle flaps, transplanting muscle, say from your back to your leg to cover a huge hole in the leg, and also for orthopedic limb reconstruction of bone loss. So that's using modern techniques that allow us to grow up to 20 centimeters of new bone to replace bone that's been blasted away by a missile or a round from an AK-47. We are starting to see a small but increasing and steady transfer of complex cases from the Ukraine into other European countries, and that includes Spain, Germany, France, the Netherlands, the Irish Republic, and all of the Scandinavian countries. We've not yet received any in the UK, but we stand ready and prepared to help. A system has been established by a coalition of nations, of which the UK is part, to have coordination, a coordination centre for these war casualties, and then to coordinate their distribution into other countries in order that we can match the right patient with the right surgical team. And this system is actually being led by the Germans. So as you can imagine, it is very efficient and working extremely well already. We are anticipating that the vast majority of cases that will need to be managed outside of Ukraine are going to be upper and lower limb injuries, arm and leg injuries from blast and gunshot wounds. And those are going to have a significant bone and soft tissue loss, plus or minus arterial or vascular injuries and severe nerve damage. And so those require treatment from a joint team of orthopaedic and plastic surgeons, as I've already mentioned, and those cases will be focused within the major trauma centres where we've got those services established already. There's also a smaller number of patients with blast and gunshot wounds to the face, but without major brain involvement, which need complex oro and facial maxillary surgery to reconstruct them. And then a smaller number again of patients who've got isolated penetrating injuries either into their chest or abdomen, and these patients are the small number who've survived these injuries tend to be left with a chronic infection. They often have a stoma, and so these need expert input from thoracic surgeons and colorectal surgeons in general. And then the final group that will require additional care outside of Ukraine is a small number of patients with spinal cord injuries who sadly are either paraplegic or quadriplegic from their injuries, and they will require a specialist spinal cord rehabilitation care, along with a small number who've got severe nerve injuries at the root of their neck, the brachial plexus injuries. So as I mentioned, there is now an established system for coordinating the evacuation of these casualties, getting them to the right surgical teams in the right country, and other countries so far have been taking cases, and the UK stands ready as the cases increase for us to help with the management of these and care of these unfortunate patients. And then the final two things just to mention, that because it's very much a broad overview, this is that so far I'm pleased to say that we've not experienced any significant cyber attacks, but obviously the danger has always been there, and there's been again a huge amount of work in the background within NHS organisations to ensure that cyber security is as good as possible within the NHS. So I'll conclude there, Neil. In summary, the NHS has provided a huge amount of medical equipment and supplies into Ukraine with a smaller but more targeted expert advice from clinicians to support clinicians within Ukraine. The biggest impact so far is the care for the 65,000 people who've arrived from Ukraine so far, and those impacts are mostly within primary care. And then we stand ready as a surgical community, the whole of the NHS, to provide care as needed for patients who are evacuated with severe war injuries.
Thank you very much, Chris, for that really superb summary, both the overall picture and some of the detail of some of the injuries and what's being done. Very, very, very comprehensive. Thank you so much. Now, Lizzie, you've been actually out there in Ukraine, and you have some slides to share with us. The floor is yours, as they say.
Thank you very much indeed. Just making sure that I'm on the correct monitor. If one of you could give me a thumbs up for that, fantastic, great stuff. Okay, many thanks in advance, first of all, for listening to my presentation this evening on UK Med's activities in Ukraine. I'll start by giving a quick overview of UK Med for those of you who aren't familiar with our work and wondering how we ended up in Ukraine in the first place. Then I'll take you on a journey with UK Med, which started on the 24th of February of this year. Our journey from the first day of the Russian invasion of Ukraine. I'll talk about our first days there, how we assessed and identified need, and then the activities that we've since implemented across the country with a focus on our surgical work at the end. So who are UK Med? So we are a frontline medical charity born of the NHS and founded by Professor Tony Redmond in 1988, which is some 35 years ago now. Our vision is clear. We believe in a world where everyone has healthcare they need when crises or disaster hits. And our mission is to save lives in emergencies. When health services become overwhelmed, we get the staff and the resources where they're needed to be. We also help communities prepare for future crises, and we work with academic and operational partners to both improve and inform patient care and the overall humanitarian sector. So just a few examples of our work then. Basically a three-pronged approach to achieving our mission is to respond, prepare, and to learn. So we respond rapidly to emergencies, delivering coordination and health expertise to support local services save lives. A few examples are Typhoon Haiyan in the Philippines, the floods in Mozambique a couple of years ago, the diphtheria outbreak on the Rohingya refugee camps in Bangladesh, the Beirut blast, and the Samoa measles outbreak, to name but a few. In the presence of NHS England colleagues, I think it's worth noting our relationship with them started with the Ebola response in Sierra Leone in 2014. I myself was a volunteer in the first round of medics that were sent out via what was a unique partnership between the NHS and the UK government and UK Med, together making available training and deploying some 15 teams to run the then DFID-funded treatment centres across the country. We were a key partner in the FCDO-led and funded UK emergency medical team, where these relationships have continued. We also have our own pre-verified emergency medical team independent of this, and both have been extremely active in responding to disease outbreak, sudden onset disasters and conflict over the previous few years. So we prepare by working with local healthcare staff to strengthen their responses, enabling services to be better prepared for emergencies. In 2020, we trained over 9,000 health staff across the world to prepare and respond to the COVID-19 pandemic. We help healthcare staff and their organisations to be better prepared for emergencies through training and capacity building, and helping to rebuild local healthcare systems and empower staff to respond against outbreaks or disasters. In South Sudan, we've delivered capacity building and training in trauma and sexual and reproductive health, and UK Med have been in Yemen since 2020, supporting the country's COVID-19 response. And then finally, we learn through academic operational partnerships, firstly with the Humanitarian and Conflict Response Institute at Manchester University. We've developed reports into key issues facing the aid system, and we've supported the Royal College of Surgeons in Edinburgh in the development of their faculty of remote, rural and humanitarian healthcare, including development of their capability framework and courses. So enough about us. Over to Ukraine. So as we know, Russia commenced a full-scale invasion of Ukraine by land, air and sea on Thursday, the 24th of February 2022. Following weeks of uncertainty and denial of plans to invade, and amid mounting sanctions and condemnation by the international community, Russia presses towards the key cities of Kharkiv, Kherson and the capital Kyiv, as well as seemingly indiscriminate attacks in other key areas and the occupation of towns such as Trostianets in northeastern Ukraine, a town which was to become a key feature in the UK Med response and one which I'll keep referring back to throughout this presentation. So our journey began on the 26th of February with the deployment of our health and operations directors, with their mission simply being to get into Ukraine and make an immediate assessment of need, find some kind of a base and get a team out. Within a couple of days, the first clinicians were out of the door with a logistics contingent to begin building key relationships and identifying specific needs in the areas identified by Tom and Ram, who you can see these two handsome chaps in the bottom left corner of the screen, with colleagues from the Polish emergency medical team. So the first days were spent sleeping in vehicles, on the floor of apartments offered by contacts we'd made in Ukraine, some of them who are working for us now, and in abandoned medical facilities. The advanced team did an amazing job, and their findings have certainly shaped our programme. So what were these findings? Well, firstly, to echo a lot of what Chris said, we found a robust and very well managed health system. The collaboration at national and local level between different elements of the health system was amongst the strongest I've ever seen, making our job of identifying needs so much easier as everyone knew who to call next. This meant that we had top-notch info for and local support of the places most in need. The hospitals and facilities that we visited were really well resourced with trained staff and a high level of equipment. There were no immediate needs at this level, although this did develop as we embedded into the country and gained the trust of local health workers and leaders. A high level of flexibility in the early stages of a response like this is really essential to develop these relationships and build trust. The high level of capacity in the Ukraine health system would certainly erode over the coming weeks and months, revealing where additional need is required in more specialist areas. And we're certainly finding that already. So our initial findings were really around the displaced population. With major cities under attack, millions fled the country, just up to 7 million up to the 1st of June. However, another 8 million are internally displaced. UK Med headed to those areas that IDPs were gathering to see if any help was needed, and responded with the setting up, resourcing and running of 5 mobile and fixed clinics in eastern West Ukraine in the first 3 weeks. Other findings revealed a need for the training of civilian first responders, so fire service and ambulance crews, who work away from the Donbass region, were ill prepared for dealing with blasts and mass casualty situations. And in the surgical domain, again, we found a very high level of capacity. However, some specialist skills in limb reconstruction and plastics, again, echoing one of Chris's points, was requested. And I'll go into this in more detail a little later. Noting that UK Med operates under the WHO Emergency Medical Team Programme, we can't start work without an invite from the government to do so. So concurrently, whilst planning and resourcing interventions that have been requested by the local health leaders, there was a need to coordinate these requests, which have just appeared up on my screen there. This is really to demonstrate that we're working under the request of and in collaboration with national and local health services to ensure we're mounting a needs-based response complementary and not bilateral to the National Health Service. Okay, so in a moment I'll go on and talk a little bit more about the activities that UK Med are carrying out. Firstly, though, I wanted to share with you this map, which kind of demonstrates where we are now from our first 2 people on the ground in late February. So we have 36 staff across Ukraine at the moment. 11 of these are national staff, mainly logistics and translation personnel, and others a mix of headquarters staff and of course our invaluable roster members. Ultimately, we aim to have at least 75% of our workforce national staff, but there have been hurdles to jump there in relation to formal registration, which is almost complete now and will enable full access to the labour market, in particular clinicians. Oh, I'm just going to skip back a couple of slides. That's where I was. Okay, so we currently have 5 field bases in strategic locations across the country, which are marked in blue on this map. And the red show where we have programme activities running but are managed remotely by nearby field bases in a hub and spoke kind of model. Up in Kyiv there, you can see that's our intention. We're looking for an office up there, which will be our country office and UK Med headquarters in Ukraine, which is very exciting. We're funded there now right through until June of next year. So there's a real need to establish a solid country programme and ensure we can support the clinicians and staff that are working there for us. So, ready for the next slide now. As I mentioned previously, there's around 8 million IDPs in Ukraine currently. During our early assessment phase, we were pointed to a city called Poltava, and discussions with the local health authorities there quickly revealed that there were over 100,000 displaced people living in the district, with probably another 50 or 60,000 that weren't registered. The needs were mainly being catered for, with makeshift IDP centres being opened at now closed schools, universities, libraries, and other municipal buildings. Local volunteers and out-of-work staff of these institutions ensured that people were clothed and fed and had a bed to sleep in. There was no access to healthcare, however, the local system completely unable to absorb that many people, and the health registration scheme in Ukraine, meaning that free care could only be accessed in the district, which was your home and where you were registered. So to counteract some of this, we set up 2 mobile clinics around the district, with hundreds of patients being seen in the first couple of weeks. A similar picture had also emerged in the west of the country, where 3 other static and mobile clinics were also serving the IDP population, predominantly for primary care needs and to ensure registration with the local health system. So some 2 weeks into my tenure as field team manager in Poltava, the Russian army changed their mission objectives, and many towns and cities close to Poltava district thankfully found themselves at the end of their Russian occupation. One such town was Trostianets, which we visited within a few days and worked with the local primary health director to mobilise clinics in these towns. Most of the doctors and nurses had left during the occupation, so instead of serving internally displaced people here, we predominantly delivered services to those who were too elderly or frail to leave, like this little lady in the bottom left-hand corner here. To date, UK Med has consulted over 1,700 patients in our mobile clinics, as I say, overwhelmingly from the IDP population, but also a proportion from the host population in those cities and areas. So emergency preparedness and training, capacity building were also identified as a real need early on in our assessment phase. With a roster of highly specialised and varied profiles, UK Med were in a position to quickly fulfil some of these needs. Partnerships were also developed to ensure that we could have a wider spread and a wider reach with our activities. And initially we worked with the Halo Trust to ensure those engaged in rehabilitation efforts were safely able to identify unexploded remnants of war or concealed landmines and ensure that those responding to any incident knew what to do for the casualty. Civilian volunteers helping those injured on the front line receive trauma first aid, and for local ambulance and fire services, always first on the scene and responsible for management of mass casualty events, receive specialised training in this and advanced pre-hospital care. As the war rumbled on, we had a lot of talk about Russia using nuclear weapons, and this increased into a real concern. We were asked to provide CBRN training to hospital medics and first responder crews, and have deployed expertise in this at every level, from heart paramedics through to Public Health England experts. We're also embedded into hospitals that have been asked to change their scope of work, which is a really important aspect of capacity building. It's not just about classroom training or one-off days. One such hospital was Cremation Veterans Hospital, used to providing solely sort of longer-term rehabilitation. Its wartime function was to take immediate post-op major trauma patients requiring HDU level care, expert nursing and early rehabilitation input. They were ill prepared for this, so the team embedded for 3 weeks and had a really good impact there. So again, we've now delivered 103 training sessions to almost 2,500 participants and completed a 3-week embed at the Veterans Hospital. Okay, on to surgery then. Our surgical advisor, Andy Kent, chap down here in the lower left, who I'm sure many of you will recognise. He was one of the first team members on the ground behind our advanced assessment team, anticipating that the surgical need would be high. We were again impressed by the resilience and capacity of the Ukrainian health system. Although of course there is some sense of having lost when requesting help. So again, we started small, developed relationships, and responded to need, and are now building a robust surgical programme across the country. There's 2 distinct elements to this programme, one being the delivery of expert training and capacity building in areas requested by the Ministry of Health, and the second is the setting up of a field surgical unit at Nhs Hospital. So seen in action above here, trauma ortho surgeon H, giving on the job training on limb reconstruction at a hospital in Dnipro in East Ukraine, and Andy Kent, who is now on his 2nd tenure in Ukraine, and establishing links for longer term support with hospitals in the West. We also have a plastic surgeon working in Dnipro hospitals at the moment. So there is a consistent and specific request for specialist training activities, again, resonating with what Chris said. So orthoplastics, maxillofacial reconstructive surgery, as well as some requests as well for paediatric trauma specialists. UK Med have also facilitated the donation and delivery of external fixators and trauma surgical kits, and will continue to work with the health authorities to determine and procure the most needed items. So finally on to Nhs then, a town that's cropped up a few times during this talk. I recall the first visit to that hospital and had a very difficult and tearful conversation with the medical director, who, along with the staff that he could retain, had just days ago emerged from the basement of the hospital, where they'd been caring for what patients they could whilst Russian soldiers shelled and vandalised the hospital above them. When we arrived that morning, there was hardly a window in the hospital, and a lasting memory for me will be the Z marked tank, which had parked itself just outside the hospital fence and relentlessly shelled it, putting the operating theatre, peds and maternity wards completely out of use, as you can see in that picture on the left there. So as grateful as a medical director was for our visit and offers of help, he half joked just before we left that unless we could get him an operating theatre, there wasn't much to be done at trusty Nhs Hospital. So me being me, off I went and spoke to the UK Med team, and over the following days, UK Med liaised with FCDO and the Ukrainian National Ministry of Health, and arranged the donation from the UK government of a field surgical unit, which, as you can see here, consists of a PACU, CSSD, operating theatre, nurses hub, and 20 inpatient beds. UK Med are now in the process of setting up the unit and hope to be operational in the next week or so. So we're going to work alongside local surgeons who are literally chomping at the bit to get back to work, and other staff, ensure they're happy with the running of the unit and eventually hand over the entire facility. So hot off the press today, a few slides of the surgical unit going up over the weekend and yesterday, and that's a really good place to leave it for me. Makes me smile. So thank you very much for listening to my presentation. I'll leave you with a few snaps of my favourite patients and clinic visitors from Poltava and Trostianets, and handing back now to the hosts. Look forward to answering some of your questions.
Yeah, thank you very much, Lizzie, for a very compelling presentation, and thanks for the real life experience of what's going on there. I guess many of us had misconceptions about the kinds of things that would be needed. I have a confession to make to everybody out there. I didn't really know until this evening what UK Med were all about properly. So that's a great education. Thank you very much. I'm sure there are many on the webinar listening who've had a great education in what UK Med are all about too. I'm sure there'll be people asking, how can I go out and help? I'm sure there'll be people asking, what bits of kit can we donate? I mean, certainly early on, we had lots and lots of requests, almost a panic for people collecting stuff and wanting to send them somehow. And of course, doing that in an uncoordinated way is probably less helpful than helpful. Jane and Eduardo, you've heard in the background, has been helping us put the show together. So Jane's collating some questions. And Jane, I wonder if you could choose the first question for our panel. Thank you.
Good evening, everyone. Yes, of course. We are getting questions through, and if people want to carry on sending them through, I will attempt to multitask as we go. So I've got a couple of questions for Chris, if that's agreeable. One of the key features of the humanitarian responses conflict has been the Ukrainian Diaspora, I'm not very good with words, my apologies, in the UK, particularly health professionals and the organisations or coalitions that they have established to raise funds and mobilise resources. Is there any advice that you can provide in terms of how these organisations can engage, if at all, with the NHS?
So it's a really good question, and we're really grateful for all the assistance and the invaluable help from everybody who has Ukrainian background, be it either first or second generation. I think in terms of equipment, I think we're at the stage where I think most of the equipment that's needed, apart from the big ticket items, Lizzie's new hospital, is there, and we're sort of in a steady state at the moment. So I think that probably the best advice is probably financial donations are probably more helpful than equipment. There will be some very specialized equipment, but that will come as a very specific request by the UK Ministry of Health or specific clinicians. I think in terms of how do you make contact, well, there is a email that you can make offers to, and I'll post that in the on the chat, if there is a chat, if I can find it. And then I think just if you're a healthcare worker within the hospital, engaging with your, chief, executive team, the medical director, or your head of service, and to say, we've got this to offer. How can we move this up the chain? But everybody I've met is willing to help and also very willing to listen.
Yep, that's great. We'll work on putting that on people's screens to see. Jane.
Yeah, if you pop it across in an email to Ed, he'll get it into the chat for you. That's great. Thank you. One for Lizzie, if I may. How is UK Med funded? And a second part to the same question, do NHS staff have to take leave, or are trusts being backfilled?
No problem at all. So UK Med, I'll start with the funding. Like any other charitable organisation, we take our funding from a wide range of donors who we have proposed work to and been lucky enough to be funded by. So just a few examples at the moment. Obviously, we're funded partly by FCDO for our contribution to their UK EMT programme. We are funded by USAID and IOM and several other agencies over the last few weeks after money has been pouring in for our work in Ukraine that I couldn't mention at the moment. But yeah, around 70% of our funding is not from the UK government, and the funding we get from them is purely for the activities that we carry out on their behalf. And secondly, so for deployments to Ukraine, there's a two-pronged approach, and it covers both of those. Some clinicians who have been finding it hard to get released from their trusts for very obvious reasons have opted to take extended personal leave and deployed in that way on a contract and salary with us. And for other people we've deployed, it's been NHS backfilled. So again, that great relationship continuing with NHS there to borrow their clinicians for these much needed responses.
So Lizzie, can I just ask, have you had too many people volunteering and the wrong kinds of people? Who's really genuinely needed?
Yeah, so it is about need, and as I'm sure you're aware, that changes all the time. So obviously over the last couple of years for COVID, it's been overwhelmingly medical staff that we've needed, and intensivists and ED clinicians and IPC specialists. But there is a different need, obviously, in Ukraine. We're deploying emergency doctors, primary healthcare. So sorry, I'll switch back to my UK head, GPs, and yeah, surgeons as well. So, but the surgeons are very much a specialist request and very much by need only. Anybody can join our register and sort of register their interest for deployment and undergoing our training to become part of our deployment roster. I was really hoping to be able to catch up with our HR lead before this webinar this evening. I was unable to, but I think the best way would be if I liaise offline with the Royal College and find a way of gathering names and profiles of potential people who would like to volunteer with us, and we'll go through HR and work out a process.
And Lizzie, in terms of surgeons then, mostly orthopedists and plastic surgeons, is that right?
Yeah, at the moment, yeah, we've had one request for paediatric trauma, but other than that, it's plastics, especially limb reconstruction, and maxillofacial surgeons as well.
Okay, great. Jane, another question, please.
Certainly. So I'm going to do a little short one, which I think is probably for Lizzie, but I don't want to make assumptions, and please apologise in advance for my pronunciation of one of these words, because it's clearly a town in Ukraine that I'm not familiar with. So I will spell it out if I need to. Do you have any surgeons here in Chnitsky. Do you need me to spell it? I'm
No,
really...
I don't need you to spell it. I have to. I don't think there's surgeons in Chernivtsi at the moment. I think we have surgeons across in the east, based in Dnipro, and then we are also in conversation with hospitals, tertiary level hospitals in Lviv, who may also be requesting specialist support. I'm not working on the Ukraine response at the moment. They've put me onto something else, but that's the latest information I can give on that.
Brilliant. Thank you. Sorry, Neil. Happy for me to go on.
Thank you.
A couple more. So we are hearing that there are a growing number of health professionals from Ukraine who've already arrived in the UK under relocation schemes. What plans does NHS England have to identify routes to provide them with job opportunities and/or experience?
Yeah,
that's
Chris,
a really good question.
Sorry, just to say, Chris, one of the asks from us or for us was, is there some way of for those medically trained, medically qualified refugees coming to the UK, for us to particularly be involved with them in terms of looking after their families? And we got the impression that it was difficult to sort of do that matching, if you like. Anyway, sorry, carry on.
Yeah, sorry, Neil. I can imagine that would be incredibly difficult. So we are very, very, very keen to, the NHS workforce, as everybody knows, is hard pressed. I know my own hospital I've just returned to has lost a lot of staff over the last 2 years, and I think there's benefits to both the NHS with different expertise coming in, and also for the people from Ukraine who I'm assuming will want to go home but keep their skills honed whilst they're working here. So we are very keen. I can't tell you off the top of my head exactly how they should go about applying, but I will make those inquiries tomorrow and see if we can arrange some form of single point of contact for anybody from medical, nursing, AHP background from the Ukraine who's arrived, to see if they can come into our system.
Yeah, great. Yes, Jane, next question.
They're coming through, so you're about to get my confused face, so regular viewers will be familiar with it. So we've got a comment really, which is I think a nice one to share. They start by saying thank you very much for all the efforts. Their view is that it would be beneficial if field hospitals occupied by ICU wards were established for receiving patients with damage control surgeries, whom would be the majority of war victims. That's just a share rather than a question. I don't know if anyone's got any follow-up on that.
Any comments, Lizzie or Chris?
So I think that for the audience who are unfamiliar, sort of you go through stages in the management of war wounds, and the first stage is obviously to save life and then do damage control surgery, which means minimum surgery to keep the patient alive, to allow you then to move them on to the next facility in the next stage. And in general, that would be within a critical care unit. Now, obviously, that becomes very difficult within a war zone. Providing critical care within a war zone is nearly impossible, and so you have to set up your any receiving critical care type unit at a distance. And I'm sure the Ukrainian government are doing that, and it's difficult to know how much assistance we can give. I don't know if you've been asked through UK Med, Lizzie, to help with that.
No, we haven't specifically been asked to look at that, and also just to note that we're an international NGO, and sort of our humanitarian principles and how we represent ourselves would hold us back from getting entirely involved with military patients, and working with the Ukraine armed forces on that. So of course I've already mentioned we're linking in with hospitals and embedding where they've been asked to upscale and care for soldiers, but taking them from the front line or joining part of that sort of system of care that requires those kind of interventions, or where that intervention would be situated, is probably a little outside of our scope in those terms.
Okay.
Super. So, oh, we've lost Chris.
Yeah, I'm sure temporarily.
I'm hoping temporarily. In which case that helps me with my question selection, because I'm going to ask the one that's directed at Lizzie. So that's very helpful. So what relationship has UK Med developed with other teams such as Médicaux Sans Frontières, International Red Cross, etc.? Are there any semi-formal networks that actually work to coordinate efforts between organisations?
Yep, there's more than semi-formal. There's lots of formal coordination mechanisms, such as the emergency medical teams coordination cell, and the health cluster. The health cluster being the one that you're more likely to find MSF and the Red Cross sat in. However, that's all at national level. We did find very early on in our tenure in Poltava that there were other actors coming in and trying to find work. So we sort of formed our own mini informal cluster, which was great, ensuring that the assessments that we were doing were not overlapping, and we were really working together to make sure that all the needs were covered, as well as the partnerships that did I touch upon? I'm not sure, with agencies like ACF, who are doing mental health and psychosocial support, which is complementing our sort of primary care mobile teams, and the Halo Trust, and many other partnerships that we've built in order to get as much help to people as possible in one fell swoop. So yeah, it's really important to us to engage and be part of those coordination mechanisms.
So Jane, we're nearly coming up to 30:30. Another question for Chris, maybe, since Lizzie's just fielded one, and then we'll.
Perfect. You literally took the words out of my mouth. That was about to be my next stage, my informal time warning. So this is not directly related to the Ukraine efforts, but a broader sort of humanitarian surgery question. So there are lots of people, as we're aware, who work predominantly in humanitarian surgery as opposed to NHS or local UK practice. But they often have difficulty maintaining their registration in the UK due to the need for appraisals, and if they don't have a designated RO, that they can sometimes have problems keeping their GMC registration up to date. Is there any way that we can look to cut some of that sort of obstructive tape to make sure that people can keep up to date with their registration and generally their sort of like safety, while still continuing to serve overseas?
You're muted just a moment, Chris.
So unusually for me as an orthopaedic surgeon, I'm going to slightly dodge the question, because I'll normally be, but actually NHS England is not the regulator, and it's just impossible for me to answer that question on behalf of NHS England. Really, you know, the regulator in the country is the General Medical Council for doctors, General Nursing Council for the nurses, and really that question needs to go to them. I think that, yeah, as a working doctor, I would support anything that we can do in the NHS from a practical perspective, with placements and mentorships and fellowships to try and keep people as current as possible in the surgical field, because it's a craft and you need to be practicing. But in terms of the regulations, you know, that really is for the GMC.
Lizzie, do you have a quick word on that from any of your UK Med employed staff or trained staff about their appraisal?
Yeah, absolutely. Just to say, yeah, we'd really like that to happen as well. Making it easier for people to come out for more than 3 weeks at a time, and giving people the opportunity to embed humanitarian work into their career, into their training programs. Yeah, I feel like we're missing out on a lot of talent because of some of those restrictions, but it sounds like that's a conversation for another day.
Yeah, from the regulator's perspective, I think, you know, that's for the NHS England's perspective, then there's a lot of local ability to be flexible on people's their work plans, allowing special leave and things like that. From my perspective, you know, I would hugely support exactly what you say. I think that it's widening people's experience and allowing them to travel and experience a very different healthcare system in a very difficult situation is a huge education, and the NHS benefits from that. We have done everything we can to encourage trusts, but ultimately it is the local medical director and the chief executive who need support. And as we've heard from Lizzie, many of them have done. But you can also understand that sometimes, you know, you have two plastic surgeons, you know, a 2-year waiting list, and if both want to go away together, you just at some point you've got to say no, we've got to provide a service.
Yeah. Okay, so a very, very big thank you from me and from the Royal College of Surgeons of England team, and for all our watchers and listeners and those who might watch it in due course on a replay, because that's going to be available for everybody in due course. I've personally found it a great education. I've been massively reassured that the response and the organisation around the response is in very, very good hands. And as I said before, Lizzie, I've learned masses about UK Med, which I never knew before, for which many, many thanks. It's been over 100 days now that Ukraine war has been ongoing, and none of us know how much longer it's likely to go on. I think we've all been reassured that appropriate measures of mitigation are in place, and I think those listening who might want to help out practically in due course have now got a way of doing that. And thank you both for giving up the time this evening. We're really, really, really appreciative. Thank you so much. And with that, I think we'll all say good night and thank you for watching. Good night.
Thank you. Good night.
Thank
Thank you.